PPT1. PPT1 Men Health. TF. Men have more morbidities than women may still live 6 years shorter than women. True. Hormone chemistry on gender health. Male menopause. Androgens. TF-AR is a ligand-dependent transcription factor that controls expression of specific genes. The binding to DHT initiates male sexual development and differentiation. True. Androgens. 5 classes of steroid hormones derive from cholesterol. Progesterone, aldosterone, testosterone, hydrocortisone, estrone. TF. Steroid hormones act by binding to a specific receptor and signaling cells to transcribe DNA in order to start expressing particular proteins. True. TF. Androgens, anabolic steroids used to help PT build up muscle mass and recover from injuries. True. Androgen ADE. Male balding, increased prostate growth, increased sebaceous gland secretion. TF. When combined to androgen receptor, testosterone itself doesn't have that function. False. Both can bind to androgen receptor, but DHT has higher affinity. True. BPH. Benign prostate hyperplasia, urgency, inability to empty, trouble. TF. One method for targeting BPH and male baldness is the inhibition of 5-A reductase. True. Finasteride. Finasteride Proscar. 5-alpha reductase inhibitor ADE, decreased libido, swell, dizzy, help, hair growth. Dutasteride Avdart. 5-alpha reductase inhibitor aid, decreased libido, ED. Prostatitis. Alpha blockers, doxazosine, cardaraprazosine, minopristerazosin, hitrin, alphazosine, uroxytril, tamsulosin, Flomax MOA, block alpha-1 ADE, hypotension, HA. TF. Prostate cancer usually progresses very slowly. True. CRPC. Castration-resistant prostate cancer medicine, DIDNT, eradicate cancer and it relapsed, Dendrian, Supinixil, TBRAND, Porvenge. ED drugs. Quit smoke, limit alcohol, exercise, PDE5 enhance vasodilatation and relaxation. MOA PDE5. Cells release nitric oxide stimulating guanylyl cyclase producing cGMP reducing calcium levels. TF. The catalytic site of PDE5 normally degrades cGMP. True. ED treatment. PDE5 inhibitor sildenafil, Viagra, vardenafil, Levitra, Staxine, tadalafil, Cialis, Avanafil, Stendra, vasodilators, androgens, testosterone supplements, tabs, injection, patch, gel, spray, transdermal solution. TF. Sildenafil is a potent inhibitor of isoenzyme type 6, localized to the eye and metabolized by CYP3A4. True. Vardenafil, Levitra, Staxine. no liver damage, no aminotransferase elevations. Ulpratidyl. Rx only expands blood vessels. Prostaglandin agonist. Male menopause. Low T onset hypogonadism. Treat testosterone hormone therapy. PPT2. PPT2UI. Stress urinary incontinence. Increase intra-abdominal pressure. Urge urinary incontinence. Urgency by overactivity. Mixed urinary incontinence. Mix of stress and urge. Overflow urinary incontinence. Overextended bladder blockage of urine flow. Impaired contractibility. Bladder obstruction. Incomplete emptying. Functional urinary incontinence. Environmental or physical barrier. Types. Stress urge overflow. Neurogenic nervous system disturb. PC. Patient had 3 childbirth and leaks when she coughs and exercise due to stress incontinence. Exacerbating medications. Alpha-adrenergic antagonists, statins, leaks, anticholinergics, block CCB, diuretics, leak hormone therapy, systemic. Exacerbating conditions. GI genitourinary disorders, neuropsych, restricted motility, diabetes equals polyuria. Therapy options. First line, behavioral training. Second line, antimuscarinics, azabutinin, darafenacin, tolterodin, trospium. Third line, neuromodulatin, onabotulinum A. AC, azabutinin. Bind to M3 no-Och binding ER/IR patch gel. AC, tolterodin. M3 ER/IR circle less than 10. ACAM, solifenacin, darafenacin, fesoterodin. Tablets do not cross BBB circle less than 30. Feso, prodrug. Clinical pearls, AC. ER preferred to IR, azabutinin patch. If ACADE too strong. Antimuscarinics not used in narrow angle glaucoma or GI emptying impaired. PTX2 agonist, mirabegron, mirabetric, vibegron, gemtesa. Bind to B3 lead smooth muscle relax, mirabegron, HTN, tachycardia, CRCL less than 30, adjust CRCL less than 15, do not give vibegron, hot flashes, NV, HACRCL less than 15, do not. PTX2 agonist, onabotulinum toxin A. Inhibit OTT release, BBW, injection, systemic sub or swallowing difficulty. PC. Patient is taking azabutinin and experiencing dry mouth and eyes. Change to patch. PPT3. PPT3 BPH. TF. DHT has higher affinity to androgen receptor than testosterone. True. BPH pathophysiology. Cell growth outpaces cell death, leading to an increased cell mass. BPH symptoms. Let's lower UT symptoms: obstructions in bladder, overactive bladder, nocturia. Diagnosis: DRE digital rectal exam PSA prostate-specific antigen. TF: the higher the number of PSA, the bigger the prostate. True. OTC alpha-1 agonist. Sudafed oxymetazoline phenylephrine. OTC anticholinergic. Benadryl doxylamine dimenhydrinate. OTC diuretic. Diurex. Refer to urologist when PSA is higher than 4. Treatments when IA is higher than I, also known as IPS. 8. PT with weak stream, no voiding and urgency. His IPS is 9 and DRE show enlarged prostate. 1. What you do. 2. What if I is 7. 3. Persistent UTI. 1. Urinalysis, med history, treatment. 2. Watch voiding, no treatment. 3. Refer. When to refer. Persistent UTI, cancer, stones, elevates PSA, Parkinson. Treatment: pharmacological. Alpha adrenergic blocker, quickest within 1 week, reduce LUTs. Alpha adrenergic blocker. Osiness, tamsulosin, solidosin, therazosine, doxazosin, alphazosin, ED, dizzy, hypotension. Warning: floppy iris. PDE5 inhibitors. First line for ED only: tadalafil, FDA approved for LUTs, aid, HAD, alpha blockers. 5 reductase inhibitors. Finasteride 5, dutasteride 0.5, block conversion T to DHT, shrink prostate, decrease LUTs, takes 2 to 6 months, aid, ED, gynecomastia, abnormal ejaculation. Antimuscarinic agents. Combo with alpha blockers, aid, anticholinergic. Warning: elderly, cognitive impaired, contra, narrow angle glaucoma. Beta-3 agonist. Not FDA approved for BPH. Combo therapies. Alpha blocker and 5 reductase inhibitors. Tamsulosin plus dutasteride may cause ED. Alpha blocker and beta-3 or antimuscarinic for LUTs if not managed alone with alpha blocker or overactive bladder. TF: 5 reductase inhibitors should not be used in LUTs if there is no enlarged prostate. True. PPT4. PPT4 ED. TF: delayed ejaculation is commonly referred as dry sex. True. TF: retrograde ejaculation is also known as dry orgasm. Ejaculate passes into bladder instead of out the urethra. True. Physiology of penile erection. Vascular, nervous, hormonal, psychological. Vascular. A. Tissues interconnected and fill with blood. B. Blood flows and outflow balanced by Alch marker. C. Erection by decrease in venous outflow. Nervous. Erection by sacral nerve reflex, nocturnal sensory stimulation, hypothalamus, dopamine. Hormonal. Hypogonadism, primary disease of testes, secondary disease of hypothalamus or pituitary. TX, testosterone. TF. Most common cause of ED is atherosclerosis. True. TF. Testosterone levels are higher in the morning. True. Exacerbating medications anticholinergics. Anticholinergics first gen Benadryl second LF CSSRI Paroxetine HD third line dopamine antagonist Reglan estrogens and antiandrogens Dicazin Spiro Cimetidine CNS depressants opiates benzos Barbie. TF. The first step in clinical management of ED is to identify and reverse underlying causes. True. 8. Smoking, alcohol. When is medication therapy warranted? Start therapy after 3 months of ED goals. Improve QOI and QNT erections. Assess after 3 weeks of therapy. Avoid ADE. Pharmacologic treatments ED. First-line PDE5 sold 50 mg VAR 10 mg tadalafil 10 mg BPH 36H 2.5 to 5 mg day of anafil 100 mg. PDE5 MOA. Nitric oxide stimulate guanylyl cyclase, increase levels of cGMP. PDE5 inhibits cGMP catabolized by PDE and converts cGMP to inactive use. Lowest dose with acceptable outcomes. TF. PDE5 inhibition inactivates cGMP. True. Vardenafil. PRN dose 10 mg daily use dose NA administration 1 hour before sex duration 10 hours metabolism CYP3A4 enzyme system. Avanafil. PRN dose 100 mg daily use dose NA administration 15 to 30 minutes before sex duration 6 hours metabolism CYP3A4 enzyme system. Tadalafil. PRN dose 10 mg daily use dose 2.5 to 5 mg day administration 2 hour before sex duration 36 hours metabolism CYP3A4 enzyme system, also used for BPH. Sildenafil. PRN dose 50 mg daily use dose NA administration 1 hour before sex duration 12 hours metabolism CYP3A4 enzyme system. AVST. mg time prior lasting of anafil 100-15 to 30 minutes -6 hours vardenafil 10-1 hour 10 hours sildenafil 50-1 hour 12 hours tadalafil -10-2 hours 36H. Cardiovascular risk stratification of patients need to know. Low risk, less than 3 risk CVD, history of MI, mild diseases, greater than OK PDE5I, intermediate, greater than 3 CVD risk, MI 2 to 8 weeks ago, moderate diseases, greater than cardio workup and stress test, high risk, MI recent, uncontrolled diseases, high risk arrhythmias, greater than no PDE5I. PDE5 inhibitor contraindications. Use of nitrates equals fatal hypotension. Hold SL nitrate. History of non-arteritic anterior ischemic optic neuropathy. PDE5 inhibitor ADE. HA priapism prolonged erection greater than 4 hours. PDE5 inhibitor DDI. Alpha blockers hypotension use tamsulosin instead. Potency YP3A4 inhibitor azoles mycin S. PPT5. PPT5 hypogonadism. Hypogonadism. decrease of function on one or more testes diagnosed. 1. Low libido. 2. ED3 loss of spontaneous erections. Test M testosterone labs 2 over 300 ng/ml. TF. 3 cardinal signs: decreased libido, erectile dysfunction, loss of spontaneous erections. True. Risk factors recognized. History of unexplained anemia, bone density loss, diabetes, exposure to chemotherapy, radiation to testes, HIV, history of narcotic use, infertility, pituitary disorders, chronic corticosteroid use. Testosterone replacement. To restore potency and libido. CI prostate breast cancer goals: get in normal range 450 to 600 with lowest dose, monitor 6 to 12 months. IM testosterone, CYP testosterone, NN testosterone, undecanoate. Effective and cheap. Oral testosterone. Poor F may cause hepatic cystity. Testosterone transdermal patch. Rotate site every 7 days. New spot: no swimming, shower. X3HR back, abdomen, upper arms or thighs. Testosterone transdermal gel solution. Do not wash or touch site for 4-6 hours. Can cover site. Wash hands. Testosterone IM injection. Q2W4 CYP and NQ4W4 und. Testosterone sub-Q. QW. Sub-Q implant. 3-6 months. Intranasal gel. TID. PPT6. PPT6 Women Health. Major sex steroids. Estrogens, progestins, androgens. TF. The most potent endogenous estrogen is 17-beta-estradiol. True. TF. Naturally occurring progestins or C21 steroids have a common unsaturated 3-keto-4-ene structure and a ketone at C20. True. TF. All 3 classes of endogenous steroids are present in both males and females. True. TF. 5-reductase catalyzes the conversion of T to DHT. Males who inherit deficiency of 5-AR are phenotypically females. Lack of differentiations during development. True. Hypothalamic pituitary reproduction axis. Continuous GnRH secretion, blocks gonadotropin. TF. PCOS disrupt hypothalamic pituitary reproduction axis. True. TF. Cancer, hyperplasia, endometriosis equals no growth hormone dependent tissues. True. TF. Menopause, hypogonadism equals decreased estrogen or androgen secretion. True. Inhibitors of gonadal hormones. GnRH agonist, lioprolide, goserelin, neferlin, bizarelin, triptorelin antagonist, cetrorelix, ganirelix, tigerelix. 5-reductase inhibitors. Primarily used for BPH2 finasteride, aid, low libido, ED. aromatase inhibitors. Reduce estrogen levels. Tamoxifen steroidal exemestane formestane non-steroidal anastrozole testrazoles aid hot flashes. Tissue-specific activity. Estrogen greater than all, tamoxifen greater than endometrium, and bone raloxifene greater than basidoxifene equals bone. Sermon clinical use. Selective estrogen receptor modulators. Tamoxifen, raloxifene, clomiphene, teremophene, basidoxifene, ospemifene. Tamoxifen inhibit estrogen grow breast cancer but stimulate endometrial growth, aid endometrium risk uterine cancer, vasomotor DVT. Raloxifene agonist bone for osteoporosis, agonist liver for cholesterol, agonist for vasomotor DVT and stroke, antagonist in breast prevent breast cancer. Clomiphene induce alate surge and ovulation, aid multiple birth. TF in obese women with PCOS, letrozole is more effective than clomiphene in inducing ovulation and pregnancy. True. Androgen receptor antagonists. Drugs flutamide, bicalutamide, nilutamide, and enzalutamide can be used to treat hirsutism. Progesterone receptor antagonist mifepristone, Ru486 misoprostol. Pregnancy termination. TF progesterone is crucial for maintenance of the endometrium during pregnancy. True. PRA asaprisnil inhibit growth of tissues from endometrium, treat endometriosis and uterine leiomyomata fibroids. Non-reproductive actions of estrogens. Bones maintain calcium content, liver improve cholesterol profile, blood increase coagulation, aid VTE. TF norethindrone and desogestrel referred to as mini pill. True, no menses, yes spotting and light period during first year. PPT7 PPT7 pregnancy item. TF decrease of albumin concentrations, decreases protein, increased concentration. True. High enzymes, high metabolism. Decreased concentration. How drug get across placenta. Diffusion less than 500, fast greater than 1000, not cross lipophilic and weak bases, cross easily, albumin high in fetus, low in mother. Molecular weight in breast milk. Less than 200 dal, bound drug not transferred to breast milk. Drugs to avoid during pregnancy. Acne isotrate, top adalapine, antibiotics, anticoagulants, HLD, HF, HTN, drugs, hormones, migraines, others. Medications to avoid while breastfeeding. Negative baby impact, decreasing milk produced in soda-fed, decrease milk and BBY agitate. TF warfarin is teratogenic. Warfarin has unfavorable properties in pregnancy, so not first line. True, enoxaparin safe, does not cross placenta. PPT8 PPT a contraceptive. TF most effective contraceptives are implants and IUD. True. FAB fertility awareness-based methods. Calendar rhythms body basal temp BBT infertile after 3 days of rising temp billings ovulation cervical mucus lactational amenorrhea LEM suckling symptothermal standard days. Female condom options. Condoms FC1 Polio FC2 nitrile diaphragm cervical cup thumb cap. Vaginal spermicides. Nonoxynol 9 high dose. Sponges. No children protect bacterial STI not viral. TSS. Toxic shock syndrome from cervical cap diaphragm sponge. MOA estrogen. Suppress FSH ethanoestradiol mestranol estradiol valerate. MOA progesterone. Block L8 surge thick cervical mucus. Progestin 4 generations. 1. Northindrone mini pill northindrone acetate ethanodyl diestate 2. Norgestrel 11 Norgestrel 3 Norgestimate disogestrel 4 Drospiridone mini pill Denugest. Backup contraceptive. Implant in CHC over 5 days after menses started BUX 7 days progestin only over 5 days after menses BUX 2 days IU injectable over 7 days BUX 7 days. PC patient missed last 2 pills. What to Yasmin? Take 2 pills today 2 pills tomorrow and continue the 1 daily. TD patches CHC. Orthovera Zafme Sulane CHC avoid DVT obese breastfeeding. Vaginal ring. Neuvering CHC avoid DVT breastfeeding. Injectable progestin. DMPA-IM and sub-Q fertility within 10 months BP under 160/100. Nixplanin. Implant progestin suppress ovulation thick mucus thin endometrium avoid obese aid irregular menstrual bleeding fertility after 30 days. ED. Skilamarina FDA heavy Kalinalileta FDA heavy Paragard ERC. ED information. Wilson disease with copper iodate painful bleed Q ED spotting 6 months heavy bleeding. Anavera. CHC avoid DVT obese. Which contraceptives to avoid in obese patients? Anavera Nixplanin TD patch CHC Torla patch Nextellus. Which contraceptives to avoid in DVT and breastfeeding patients? Patches and vaginal rings. Which contraceptive to avoid in high blood pressure patients S greater than 160 and or D greater than 100? Depot shot fertility 10 months. Emergency contraceptive FDA approved. Ella and Plan B 1 step. OTC 11 Norgestrel Plan B. Suppression of ovulation dose 1.5 mg prefer 72 hours but okay 5 days/120 H. Ella. Rx only 120 hours/5 days preferred in obese progesterone agonist-antagonist ulipristal 30 mg. Prevent an increase of LH and FSH. High level of estradiol stop menstrual flow. Increased levels of estrogen component stop breakthrough bleeding. Combined hormonal contraceptive CHC. No migraine with or equals stroke, smoking, HDN, diabetes, obese. TF. Taking combined hormonal contraception after postpartum has VTE risk factors. True. Also avoid during breastfeeding within 21 days of birth. Drug interactions. Inducer anticonvulsants antibiotics. Which of the following combined oral contraceptives should potentially be avoided in a woman taking lisinopril? A. SB seasonale C. Junofay decurriva. A. Yes. 8. Estrogen and progestin. Estrogen, nausea and throughout bleeds. Progestin, weight gain, late pack bleeds. TF. Drospirenone 1 mg has no androgenic activity. True. Help with acne as CHC. ADE of CHC equals X. A. Pains C. Chest pain H. Headache C. Eye problems S. Severe leg pain. How long can Mirena registered trademark remain inserted to provide protection against pregnancy? A. 3 year B. 5 years C. 8 years D. 10 years E. 12 years. C. 8 years. How long does EAD last? Skilla 3 Kylina 5 Liletta 8 Mirena 8 Paragard 10 Q EAD. TF. After discontinuing a combined oral hormonal contraceptive, it may take 3 to 4 months to see a return to fertility. False less. Torla. Patch Q7 DCHC. No obese, no smoking. SLYD. Progestin only equals drospirenone 4 mg CI. Renal, adrenal, cancers, liver, uterine bleeds. Next Ellis. CHC obese. Appeal. Progestin only norgestrel. Vasectomy. Takes 3 months. Breast cancer. Only QED. Sepsis, cervical endometrial cancer, pelvic uterine problems, gestational trophoblastic disease, post-abortion STD, TB, vaginal bleedings. No ED. PPT9. PPT9 drugs in pregnancy and lactation. Peripartos. Deliveries after 20 weeks. Gravida. Number of total pregnancies. Folic acid. Always take in pregnancy 0.4 to 0.9 mg day. Prevent NTD neural tube defects. Iron. 27 mg day if anemic. 60 to 120 mg day. Prevent spontaneous abortion and premature delivery, anemia and low weight BBY. Calcium. 14-18 Yo 1300 mg day 19 plus Yo 1000 mg day fetal skeleton and teeth decrease risk of HDN and preeclampsia. Vitamin D 15 mcg day prevent disordered skeletal homeostasis in newborn. Iodine 150 mcg day nervous system development. Pregnancy vitamin doses. Folic acid 0.4 to 0.9 mg day, iron 27 mg day if anemic, 60 to 120 mg day, calcium 14-18 Yo 1300 mg day 19 plus Yo 1000 mg day, vitamin D 15 mcg day, iodine 150 mcg day, morning sickness vitamin B6 equals 10-45 mcg TID. Casey, which of the following vitamins minerals always requires supplementation in pregnancy? A. Vitamin A, B. Vitamin B6, C. Folic acid, D. Vitamin E. C. Folic acid. TF. TDAP vaccine needs to be administered during each pregnancy because of pertussis. True. Known teratogenic agents. Alcohol, cigarettes, cocaine, thalidomide. Many ADE stop making drug altogether. ACR, statins, DOAC, NSAID, therm hormones, lithium tetracyclines. Which of the following prescription medications is a first-line treatment option for nausea, vomiting in pregnancy? A. Diclogis, B. Promethazine, C. Zofran, D. Protonix. A. Diclogis. NVP pharma treatment. First line, Vit B6, Diclogis, antihistamine, H1, Benadryl, Meclizine, hydroxyzine, demenhydrinate. Second line, Promethazine, prochlorperazine, metoclopramide. Others, Zofran 4-Pomadryl, ginger. GERD. First line, antacids equals calcium carbonate. Second, H2R atidines. Third, PPI, zoles. Thromboembolism. Pregnant women are a walking potential clot drug. LMWH warfarin only if mechanical valve. Which of the following should be avoided in a constipated pregnant patient? A. Psyllium, B. Polyethylene glycol, C. Docusate, D. Mineral oil. D. Mineral oil can exacerbate contractions. Pregnancy-influenced issues. TF. In diabetes, insulin is always preferred since it doesn't cross the placenta. True. Casey, a patient comes into your pharmacy to ask about treatment options for morning sickness. You recommend vitamin B6. The patient replies, but my prenatal vitamin already has B6 in it. Isn't that too much? Vitamin B6 in multi 25 mcg. She needs 10 to 25 mcg TID and might want to add doxylamine. Issues in pregnancy. UTIs. Treat ASAP STDs. HA. Allergic rhinitis. Use chlorpheniramine as antihistamine or budesonide as nasal steroid. Pharmacologic drugs for UTI and pyelonephritis. UTI, nitrofurantoin before 37 weeks, cephalosporins, pyelonephritis, for hydration, cephalosporin, Pen-V, gentamicin, Tylenol for fever, NO-nitro. Genital herpes. Acyclovir or valacyclovir at 36 weeks. C-section to avoid transmission sometimes necessary. Headaches in pregnancy. Tension, Tylenol, no NSAIDs after 20W migraine, same as tension plus antiemetic sumatriptan for acute propranolol prophylaxis. Which of the following treatment options should be avoided in a pregnant patient with a UTI? Ciprofloxacin, cefuroxime, tetracycline, cephalexin. Tetracyclines and ciprofloxacin. Which of the following agents is the agent of choice for the preventative treatment of migraines in pregnant women? Sumatriptan, propranolol, amitriptyline, or iodamine? Propranolol. Epilepsy in pregnancy. Avoid valproic acid, phenytoin, carbamazepine and phenobarbital. All take folic acid. Which of the following hormones is responsible for milk production? A. Prolactin. B. Oxytocin. C. Progesterone. D. Human chorionic gonadotropin. A. Prolactin. Milk expulsion, oxytocin. Which of the following medications may be used to stimulate prolactin secretion in lactating mother? A. Ibuprofen. B. Magnesium sulfate, C. Lanolin. D. Metoclopramide. D. Metoclopramide 10 mg BID to TIDX 7-10 days. Mastitis. Clogged infection. Treat diclexacillin 500 mg QID 10 to 14 days, cephalexin 500 mg QID 10-14 DNSAID, ibuprofen. Which of the following is a contraindication to breastfeeding? A. Mother with mastitis. B. Mother who received the COVID-19 vaccine. C. Mother who received the yellow fever vaccine. D. Mother with asymptomatic herpes simplex virus. C. Mother who received the yellow fever vaccine, smallpox 2, chemoherpes, galactosemia. Postpartum mood disorders. Non-pharmacological, psychotherapy, pharmacological, antidepressants, PP, depression only, FDA approved equals brexanolone if infusion. PPT10. PPT10 endometriosis. Endometriosis pathophysiology. SSX, painful, infertility, retrograde menstruation, chalamic metaplasia, 4 stages, 1 to 2 lesions, 3 to 4 adhesions. Pain management. NSAID, acetaminophen surgery. GnRH agonist and antagonist. Help reduce size of endometrium and help with pain management. Hormonal therapy. First line, progestins. Progestins only, better for deep infiltrating lesions and dysmenorrhea. In endometriosis, northindrone is progestin of choice. True Love, norgestrel, DMPACOC, low-dose estrogen plus progestin. TF. As we get older, GnRH agonist level decrease and estrogen might turn off, called a postrogenic state. True. TF. Menopause, decrease estrogen leading to osteoporosis, vaginal dryness, hot flashes. True. GnRH agonist. Treat hyperestrogenic flare effect. TF. GnRH antagonist and their doses are very specific for endometriosis. True. GnRH antagonist. Orlisol, reduce endometriosis pain 150 qd, mod savve pain 200 bid, dyspareunia or unresponsive, max duration 24 months for 156 months for 200. TF and back therapy should be started at the same time as GnRH agonist. True. Second-line androgen. Donazole second-line due to ADE masculine traits. Endometriosis in adolescent and young patients. First NSAIDs, then first-line continence COC, progestin only or LNG-ID. Summary of endometriosis. Endometriosis, pain by inflammation by lesions outside endometrium. First line NSAIDs for SX control and progestin only, lower estrogen and androgenic progestin. Norethindrone or DMPA GnRH antagonist is high specific for endometriosis and used during painful intercourse. Management of uterine fibroids. 1. Myomectomy to remove tumors and preserve fertility. 2. To preserve uterus. Also myelin embolization. Ultrasound surgery. 3. Not preserved either. Hysterectomy. TF. Myomectomy is a surgical procedure to preserve fertility. True. TF. Hysterectomy is the procedure to not reserve either fertility or uterus. True. Definitive cure. UF treatment. Tranexamic acid to reduce blood loss and fibroids. LNG treat abnormal uterine bleeding. Orion. Norethindrone, Elegalex, estradiol GnRH antagonist plus progesterone plus estrogen equals help reduce abnormal bleeding and reduce size of endometrium. Max 24 months use. UF summary. First line GnRH antagonist, androgenic progestins to reduce bleeding, tranexamic acid to stop bleeding. PPT11. PPT11 PCOS. PCOS. Polycystic ovary syndrome, endocrine metabolic, excessive body hair and hirsutism, overweight, irregular menses, acne, abnormal LH, FSH, insulin resistance, excessive androgen. PCOS diagnostic criteria. Rotterdam on ovulation, hyperandrogenism. Weight modification. Weight loss 5 to 10%. HIIT exercise. Metformin GLP-1 agonist. Inositols help insulin resistance, restore ovulation. TF. Inositols is an OTC supplement used to help PCOS. True. PCOS menstrual irregularities. COC progestogens, insulin sensitizers, metformin, thiazolidinediones. PCOS hirsutism and or acne. COC antiandrogens, spironolactone, finasteride, eflornithine. PCOS infertility. Metformin only, clomiphene, letrozole. PCOS weight loss. Insulin sensitizers, metformin, thiazolidinediones. Oligomenorrhea. Irregular obese equals change lifestyle, non-obese equals COC and metformin. Combine oral contraceptives. Estrogen suppress LH, progestin inhibit LH, progestin of choice in PCOS, COC. Low androgen, desogestrel and norgestimate or antiandrogen despyronone, very low dose estrogen. Metformin dose in PCOS. 850 mg TID. Hirsutism treatment. Spironolactone teratogenic drospirenone finasteride teratogenic eflornithine thins out hair. PCOS summary. Weight loss 5 to 10%. Added therapy equals metformin anti-androgen progestin equals drospirenone. First line lifestyle. PPT12. PPT12 infertility. Male infertility. Treat underlying issue. Hypogonadism is a component. First line UE or artificial insemination. Second line IVF. TF. Hypogonadism is a component of male infertility. True. Female infertility pathophysiology. Tubal factor, history or pelvic infection or endometriosis, uterine factor, endometrial polyps, Mullerian anomalies, UF. Risk factors for infertility. Smoking, obesity, illicit drug use, drinking. Ovulation induction. Selective estrogen receptor modulator, aromatase inhibitor, gonadotropic releasing hormone agonist and antagonist, human chorionic gonadotropin. Selective estrogen receptor modulator. Enhance follicular maturation process and ovulation. Clomiphene citrate male, sperm production and ejaculation female. Increase LH and FSH and ovulation. 3 cycles limit to 650 mg. Aid hot flashes. Aromatase inhibitor. Block conversion of androgens into estrogens. Create hypoestrogenic state. Release LH and FSH. Ovulation induction. Letrozole and estradiol. Gonadotropins. Recruitment and development of multiple follicles. Step up step down protocol. Monotropins. Monopor 75 IU 150 IU. Philotropin. GnRH agonist in infertility. Allow optimal duration of gonadotropic administration to maximize follicular maturation. Leuprolide, neferlin, gosfrelin 7 days prior to gonadotropins. TF. Gonadotropins multiple the number of follicles. Monopor, monotropins, philotropin. True. GnRH antagonist in infertility. Suppress gonadotropic release. No premature LH surge. Cetrelix equals cetratide. Ganirelix equals furimidol. HCG, human chorionic gonadotropin. Stimulates natural LH surge to trigger ovulation. UHCG, Profazi and Pregno RHCG, ovidual shots. Os ovarian hyperstimulation syndrome. Treat dopamine agonist equals carbagoline. Hyperprolactinemia. High prolactin levels. Bromocriptan, carbagoline. Infertility summary. Meds. ADE hot flashes. PPT13. PPT13 sexual dysfunction. Incidence, pathophysiology, risk factors, symptoms. Distress in sexual desire, arousal, pains, risk, medical conditions, mental, relationships, vulnerability, psychiatric, culture, SSX, VMS, hot flashes, sweats, anxiety, GMS, dryness, low lubrication, pain, UTI. Exacerbating med comorbidities. medications-associated anticholinergics, anticonvulsant psychotics, BB, diuretics, opiates, clonidine, benzos, SSRI, SERMs. Pharmacological and non-pharm therapies for female dysfunction. Non-pharm, psychology interventions, toys, negative thoughts, behavioral training, pharmacological, FSD plus pain equals low estrogen, progesterone or ospemifene, FSD VMS equals low dose systemic hormonal hypoactive fibinserin, sexual interest arousal equals transdermal testosterone. Genitourinary syndrome of menopause. Low-dose estrogen vaginal tabs, gels, creams, and rings, osphena, vaginal dryness and dyspareunia and atrophic vaginitis, FDA introsa, dyspareunia, atrophic vaginitis, FDA. Vasomotor symptoms. Use lowest dose use with progesterone unless hysterectomy, clemiprimpro estrase. Low sexual desire. Philbinserin, ADI 100 mg per menopausal females, REMS, alcohol use equals severe hypotension and syncope, low dose testosterone patch DC after 6 months if no response, Covarix for hot flashes with menopause, bupropion XL use for SSRI induced sexual dysfunction. PC. Patient started Lexapro and felt low sexual desire right after not going through menopause and everything else seems alright. What to do? Titrate off Lexapro and start on bupropion 150 qd 3 days BID. PPT14. PPT14 menstrual disorders. Normal cycle, endometrial changes, hormonal behavior. Days 0 to 4 menses, low hormones 4 to 10, endometrial layer build, ovum develop 10 to 13, estrogen surge equals LH and FSH surge 13 to 15, ovulation, estrogen, LH and FSH decline 15 to 28, LH and FSH and estrogen low, progesterone develop layer, then drops. Pathophysiology, clinical manifestation criteria for various disorders. Amenorrhea, no menses 90 days, primary equals none, I-15 secondary equals none for 3 cycles or 6 months. TF. Amenorrhea itself is not a diagnosis but a sign of pregnancy or disorder. True patho, no progesterone. Amenorrhea treatment. Primary estrogen, Premarin patch, Clemora, Allura, Estratum, COC secondary, oral DMPA, Provera, northindrone, Agestin, microprogesterone, Pometrium, progesterone, hyperprolactinemia, bromocriptine, arlodol. Hyperprolactinemia. Stop offending agents, drug-inducing, psychotics equals haloperidol, prochlorperazine, drug to treat, bromocriptine. Premarin. Hormonal therapy, primary amenorrhea, ADE, VTE, HA, nausea, tenderness, GI, bloating. Which of the following is considered a drug of choice for a patient with hyperprolactinemia? A. Combination hormonal contraceptive pill. B. Ethanoestradiol patch. C. Oral medroxyprogesterone. D. Bromocriptine. D. Bromocriptine. Heavy menstrual bleed, HMB. SSX, pallor, tachycardia, fatigue treatment, CHCl, NG, PODMPA, NSAIDs, tranexamic acid or ion. If a patient wishes to avoid contraception, what is the first-line therapy for heavy menstrual bleeding? A. Endometrial ablation. B. Oral ethanoestradiol. C. Tranexamic acid. D. NSAIDs. D. NSAIDs. Dysmenorrhea. pelvic pain rule out pregnancy release prostaglandins greater than inflammation response SSX, HA, and V, low BACL pain, cramping 8-72H straight NSAIDs and contraceptives. Abnormal uterine bleeding with ovulatory dysfunction. Irregular HMB caused by oligo or anovulation causes PCOS, perimenopause treat hormonal, metformin aid diarrhea. Pharma and non-pharmacologies therapies associated ADE of pharmatherapies. Which of the following is the most common cause of ABO? A. Extreme exercise. B. PCOS. C. Diabetes. D. Stress. B. PCOS. PMS. PMDD. PMDD, mood-altering coil treat PMDD, clomipramide drospirenone leuprolide GnRH agonist SNRI, venlafaxine PMS, SSRI citalopram, SC, fluoxetine, sertraline. PPT15. PPT15. Objective terminology and definitions. MOA contraindications. ADE. Gravida, number of total pregnancies. Parity, number of total deliveries after 20 weeks. Preeclampsia, HTN with proteinuria or organ dysfunction after 20 weeks. Impaired blood supply, placenta dysfunction. TF, pregnancies can still be aborted or miscarries during 20 weeks. True. Hypertension in pregnancy. Chronic HTN gestational preeclampsia, seizures, HA, SOB preeclampsia with severe features. HBP, low platelet, visual disturbances. HELLP syndrome, hemolysis, elevated liver enzymes, low platelets. Eclampsia, one or more seizures, low blood flow to uterus, SOB and kidney issues. TF, preeclampsia comes with HTN with proteinuria or organ dysfunction. True. Aspirin 81 mg. Do not recommend for low risk, only for 2 moderate and 1 high risk score. HBP treatment. Keep BPS 120 to 160 D 80 to 110. Aggressive treatment not recommended. Severe HTN over 160/110 for labetalol aid. Bradycardia, fastest onset for hydralazine, not for cadpionifedipine IR for outpatient. Seizure prevention. Magnesium sulfate first line for eclampsia. Dilute mg 20 to 30 minute bolus. No need to get it to target aid. Flush. Hypotension, severe aid. Respiratory paralysis. Cardiac death. KC 1. How do we define gravida? A. Number of times given birth greater than 20 weeks of gestation. B. Number of times given birth greater than 39 weeks of gestation. C. Number of miscarriages. D. Number of times pregnant. D. Number of times pregnant. 2. Which of the following are not present in gestational hypertension? Select all that apply. A. New onset hypertension. B. End organ dysfunction. C. Proteinuria. D. History of chronic hypertension. B. End organ dysfunction. C. Proteinuria. D. History of chronic hypertension. 3. What is the goal blood pressure for management of hypertension in pregnancy? A. 110 to 150 mmHg/80-110 mmHg. B. 120 to 160 mmHg/90-120 mmHg. C. 120 to 160 mmHg/80-110 mmHg. D. 130 to 140 mmHg/80-90 mmHg. C. 120 to 160 mmHg/80-110 mmHg. 4. What agents can we utilize in the treatment of hypertension in pregnancy? Select all that apply. A. Labetalol. B. Aspirin. C. Nifedipine. D. Hydralazine. A. Labetalol. C. Nifedipine. D. Hydralazine. Aspirin used for prophylaxis based on risk factors. PPT16. PPT16 Labor and Delivery. Objectives: medications used to prevent preterm labor. Purpose of medication during labor. Farm recommendation for obstetric complications. Labor induction. Prostaglandins, misoprostol, dinoprosmtone. Delivery within 24 hours. Oxytocin, pitocin. Most common softens the cervix. TF, PGE1 and PGE2 are the main prostaglandins used in cervical ripening and labor induction. True. Pain management during labor. Pain worsen with new mother, young, high weight. Oxytocin, magnesium sulfate. Pain management. Narcotics, unreliable. Respiratory depression of both butorphanol. Opiates. Epidural, spinal block. Infections during labor. Antibiotics to treat mother and prevent neonatal infections. Safe. Flagyl cephalosporins. Vancomycin, aminoglycosides. Avoid tetracyclines, fluoronitrofuration, sulfonamides. Group B strep. Penicillin, ampicillin, PENV. Allergy, low cefazolin, high vancomycin, clindamycin. Fetal management. Premature rupture of membrane. Corticosteroids. Fetal lung 24 to 36 weeks. 1 to 2 courses within 7 days of risk delivery. Betamethasone, dexamethasone. Preterm labor management. Tocolytics delays labor. 48H to 1 week. Mg sulfate beta agonist. Terbutaline, CCB, nifedipine, NSAID. Indomethacin prevention. Progesterone, reduce spontaneous birth. Patient going into preterm rupture. What recommendation? BP 166/96. Penevillin for prophylaxis. Corticosteroid to protect baby. Betam or Dexam. No tocolytics. No labor sign of preeclampsia. Same patient had delivery but lost blood. Recommend? Oxytocin prevents hemorrhage. Prostaglandins present uterine contractions. Stop blood loss. Postpartum hemorrhage treatment. NaCl 0.9% uterotonics. Oxytocin, prostaglandins, methylarginovine, tranexamic acid. C-section. Cefazolin antibiotic. Higher mortality and morbidity than vaginal birth. PPT 17. PPT 17 Menopause. MJ is a healthy 53-year-old female. She reports her last menses was 9 months ago and she has been having hot flashes and drenching night sweats. MJ is likely experiencing A. Menopause, B. Perimenopause, C. Postmenopause, D. Early onset menopause. B. Perimenopause. Is menopause a disease? No, it's a natural aging process. TF. Menopause can be premature or induced. True. Menopause pathophysiology. Release of androstenedione greater than estrone low stop estrogen and progesterone levels. Menopause SSX. VMS, hot flashes, night sweats, GSM, genital atrophy, dyspareunia, UTI, UI site changes, depression, sleep joint and muscle pain, sexual dysfunction, dry skin, osteoporosis and fractures. Need estrogen. Cardiovascular, HLD. Symptoms and complications of menopause occur due to A. Decreased levels of FSH/LH and estrogen. B. Increased levels of FSH/LH and estrogen. C. Decreased levels of FSH/LH and increased levels of estrogen. D. Increased levels of FSH/LH and decreased levels of estrogen. D. Increased levels of FSH/LH and decreased levels of estrogen. Management. Non-hormonal strategies. Selective serotonin reuptake inhibitors. Paroxetine, fluoxetine, escitalopram, citalopram, and HA cause serotonin syndrome. SSRI increased bleeding. SNRI venlafaxine as alternative. TF. SSRI non-hormonal causes serotonin syndrome. Trubrosdel 7.5 mg QH for VMS. New drug Veoza. Fezolinetant restores normal hypothalamus activity. Contraindicated in cirrhosis. Circle less than 30 ml. Check liver Q3M. TF. Veoza new drug to restore hypothalamus. Contraindicated in patients with cirrhosis. True. Vaginal lube versus moisturizers. L. Dryness after sex relief. M. Increase mucosal, decrease pH supplements. Avoid in cancer patients. Not really helpful. Which of the following agents would be the best option to treat moderate to severe hot flashes causing sleep disturbance in a 55-year-old woman with history of estrogen receptor-positive breast cancer currently taking tamoxifen? A. Venlafaxine. B. Estrogen. C. Paroxetine. D. Phytoestrogen supplement. A. Venlafaxine and Veoza. What is the first-line therapy for a 58-year-old postmenopausal woman suffering from mild genitourinary syndrome of menopause? A. Intravaginal moisturizer and lubricants. B. Intravaginal estrogen cream. C. Paroxetine. D. Clonidine. A. Intravaginal moisturizer and lubricants. Mild Paroxetine and Clonidine for VMS. Trial 2. Single-agent estrogen. Prior hysterectomy history benefit. Decreased osteoporotic fracture risk. Stroke. VTE. Trial 1. Combine HRT. Intact uterus benefits. Decreased osteoporotic fracture risk. Stroke. Cancer. Too much estrogen can cause endometrial cancer. True uterus equals combined therapy. Progesterone protect. No uterus equals only estrogen. When start hormonal therapy? Before 10 years of menopause. TF. Vaginal estrogen have no been associated with CHD. True. VTE risk higher in oral therapy greater than transdermal greater than vaginal breast cancer less risk in vaginal products. Data from the WE studies demonstrated that conjugated equine estrogen therapy alone or in combination with MPA significantly increases the risk of A. Coronary heart disease, B. Stroke, C. Colorectal cancer, D. Breast cancer. B. Stroke. Estrogen increase risk of VTE and stroke. TF. Most favorable risk-benefit ratio is for women less than 60 years or within 10 years of menopause. True stop after 5 years of therapy VMS, systemic therapy GSM, intravaginal therapy. Management of menopausal hormone therapy. VMS plus minus GSM and uterus, combo without uterus, estrogen alone mod savvy GSM only, vaginal estrogen progesterone not recommended except Phamaring use with progesterone. A. Hormonal therapy is the most efficacious therapy for her vasomotor symptoms. C. Risks are less in women younger than 60. Which of the following intravaginal estrogens is also approved for treatment of vasomotor symptoms? A. Estring, B. Vagifem, C. Phamaring, D. Imvixi. C. Phamaring. Pharmacological management of menopause estrogen. Premarin oral 0.3 to 0.45 mg qd, max dose 1.25 mg qd TD estrogen, Favaldoc topical, Phamaring, systemic concentration also for VMS, added progesterone. Pharmacological management of menopause progesterone. More expensive POMPA Northindrone TD combi patch. Continuous progestins is preferred over cyclic. D. Transdermal estrogen with micronized progesterone. D. Intravaginal estrogen cream. Which of the following CYP450 enzymes metabolizes both estrogen and medroxyprogesterone? A3, A4, B1, A2, C2, D6, D2, C19. A3, A4. Management, pharmacologic other hormonal therapies, SERMs. Raloxifene aid VMS FDA prevent osteoporosis, osphena, severe dyspareunia and GMS symptoms. Estrogen plus basodoxin prevent osteo-BBW, VTE/stroke in over 50-year-old. Continued vasomotor symptoms in a 52-year-old postmenopausal woman with a history of hysterectomy receiving 0.3 mg of oral conjugated equine estrogens can best be managed by A. Changing to a SERM, B. Changing to gabapentin, C. Increasing the daily estrogen dose, D. Decreasing the daily estrogen dose. C. Increasing the daily estrogen dose. PPT18. PPT18 hormone therapy, gender affirming care. Criteria for hormone therapy. Persistent body dysphoria, 6 months, capacity of decision and consent, mental health, controlled voice changing SLP. Surgical interventions. Top surgeries: mastectomy, breast augmentation, bottom surgery, vaginoplasty, phalloplasty, metoidioplasty. Feminizing pharmacotherapy, estrogen. High-dose estrogen PO estradiol 2 to 4 mg TD estradiol 100 mcg eval IM 20 mg Q2W ESIP IM 2 mg Q2W patch preferred low VTE. Feminizing pharmacotherapy, antiandrogens. Spironolactone 25 mg if spiro not tolerated, finasteride destatride. TF for female transfer process always need an estrogen and antiandrogen. True. Feminizing pharmacotherapy, progestin. MPA-PO Provera 2.5 mg HSD-PO 150 Q3 MPO progesterone minus 100 mg use if combo DOESNT work. Feminizing pharmacotherapy timeline. Short short-term effects: decrease sexual desired, spontaneous erection medium, decrease muscle mass, decrease testes, decrease body fat distribution long, decrease hair growth and sperm production. Masculinizing therapy. Testosterone IM recommended TNNT SIP 100 to 200 IM sub QQ2WT 1000 mg Q6W, then Q12WT gel 50 to 100 mg day TD 2.5 to 7.5 mg day. Start low dose equals mood swings. Progesterone. Suppress menses progestin only COG VTE. Start therapy for patient with testosterone sub at 100 mg IM every 2 weeks. Drug interaction. Estradiol equals SIP 450, testosterone equals warfarin, paclitaxel, bupropion, spironolactone equals K diuretics, lithium, digoxin. Adolescent. Tanner stage 2 pubertal. Non-binary. Low doses of opposite GnRH to maintain neutrality, anti-androgen alone.